Well, let's start off by talking about diabetes in older adults. So, Paul, what's your approach when you get the family coming in high fiving that their, 92-year-old grandfather or father with dementia has an A1C of 5.5%? What's your approach to that one?
At first, I validate them and congratulate them. You don't want to deflate their balloon because I think it's nice when people achieve goals, especially when they're very oriented towards their health. But I think the point you're making, Matt, is that when I see an older patient whose A1C starts to dip down, and especially like is approaching euglycemia, and they're on things like insulin or they're on like a sulfonylurea, that's when I start to get a little bit nervous that we might be being overly aggressive and really increasing the risk of hypoglycemia, which can be
Yeah.
bad for everyone, but especially in older patients, it can really impair cognition, which is not what you want to do.
Yeah, I mean, it matters the way you get there, right? So if it's just naturally 5.5 because they've lost weight or they're just eating differently, then
Yeah,
that's okay, obviously. It's more the people that are on insulin, sulfonylureas,
right,
medications that can
exactly.
cause hypoglycemia where I worry about it. Or if the person's A1C is 5.5 and they're on metformin and they hate taking metformin, they want to try to scale back on that or stop it altogether, I will run that experiment with them, but I'm not necessarily pulling metformin off if the A1C is low, because that I think that's low risk of harm. So I just wanted to make that caveat there.